Good
Yeah.
morning.
Good
Good
morning,
morning.
Dr.
Morning.
D'Amico.
How we doing?
Good. How are you?
I'm great. Always great. How's BRAINterns been going?
Really?
BRAINterns have been going great.
Yeah, people are loving it, we feel.
Yeah.
The
Yes.
content's been good. I know we put together this incredible list of people to talk, which I do love.
Brain turns in the chat. Share your feedback. What is your impression of the program so far? Have you had a favorite talk? We'd love to hear from you.
That's true. Definitely post it on social media and definitely find me on social media. It's always so funny because the scheduling is so difficult because you're being taught by real doctors who have real lives and who have to deal with real patients, and stuff comes up and doesn't come up and things change very, 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 very quickly. For instance, tomorrow is usually a day that I'm relatively free, and now tomorrow I'm operating all day long. And that's something that I even planned or didn't plan but planned. Whereas sometimes it just happens and you don't plan it at all. Ooh, they love pediatric neurosurgery. I love that too.
Yeah.
Well, it's 9:01. My name's Randy D'Amico. I'm one of the neurosurgeons here at Lenox Hill. I'm here with Hannah Flam. I'm here with Samantha and Christy, who have been your guys' kind of Sherpas through your neurosurgical journey as you climb to the top of Mount Lenox Hill, or I guess Lenox Hill. You just climb to the top of the hill. We learn a lot about neurosurgery that way. I'm supposed to be giving an innovation in neurotechnology talk today, which I think I'm going to do. I actually have something that I've put together before and talked about this. It's very vague. It's going to be just kind of like an overview of some of the cool stuff. We live in an extremely exciting time when it comes to technology, and I think we should not be afraid of that. We should really fully embrace it. It's super cool, and I'll talk to you about a bunch of that stuff. After me, a little bit of a scheduling situation where instead of starting exactly at 10, we're starting at 10:30. Am I right, Hannah?
Correct.
Yes, and we're going to have Dr. Anlu from out in Long Island. She's a neurosurgeon, going to talk about, really the women in neurosurgery experience. It's been a staple in the BRAINterns programming. I think it's very, very important and enlightening to always hear from, different people. You'd be surprised, people telling their story gives a lot of insight because you find a lot of similarities in terms of what people have been through and what they're going through and what they will go through. And you can kind of tie that in with your own life also, which is great. And then who do we have at 11 today?
At 11 o'clock. Oh, where did my schedule go? Ah, I have it here. I have too
I
many
lost
tabs
one.
open.
Oh, we have
Uh,
the Tamika and Co. We have
yes, at 11 o'clock. Yes, and they've confirmed. So our clinical research team will be
yeah,
speaking with you guys about um,
how to
the
do
world of clinical
research.
trials. Yeah.
Yeah. Which is so important. It's one of the big things that we do here at Lenox, where we run a really robust clinical trials department. And for some of the diseases we treat, unfortunately, clinical trials are the only hope. And they're going to talk to you about why it's important and how it's the only way to get things done in the future. And so, we have an exciting day and an exciting rest of the week. It feels like a short week. It's not really a short week, but it feels like it. And why don't we get started? I'm going to share my screen. Give me a sec. All right, can everyone see this?
Yes.
Neurosurgery, technically it's not rocket science. I think this is the same talk. Wait a minute, hold on, let me just make sure. I want to make sure it's the right one and not the wrong one. Yes, this is the right one. Okay, good. All right, so you guys can see that. So I'm me. I started BRAINterns a while ago. I'm assistant professor of neurosurgery here at Lenox. I'm director of the Brain and Spine Meds program. I'm a brain and spine tumor surgeon. That's really my passion. I do a little bit of everything though, and I was trained at a great place, so I know how to do a little bit of everything, which is nice. Today, I wanted to talk to you guys about this is us. You guys know this already, about technology and why it's so important to neurosurgery.
Dr.
And yeah.
Sorry, you need to reshare your screen.
Oh, you can't see it?
No.
All right, there.
Yes.
So what I was saying was, this is me, that's them, this is us now. All right. Um, so tech has changed everything that we do in every aspect of life. But this is, in neurosurgery, it's really, really, really cool. This picture on the far left is the original CT scanning machine. And that's the image it produced right next to it on the right side, this kind of gray scale. They have a little key at the bottom. And CAT scanners measure density. But what's wild about this is this machine was actually invented by a record company, the Beatles record company. And they transformed it into medicine, and it transformed neurosurgery, because before this, in order to find out where pathology was, you had to be a good neurologist, where you had to figure out where the lesion was in the brain or in the spine based on symptoms. And then you did stuff that was even crazier, like an air pneumoencephalogram, where they would inject air through a lumbar puncture in your spine and flip you upside down on a table and see how take an x-ray and see how the brain looked expanded or not based on the air pattern. Very, very cryptic, very difficult to interpret, as you can imagine. We would do these surgeries that were essentially exploratory. They would remove a giant portion of your skull and go look at for stuff based on where they thought it was. Which is interesting. But then the CAT scanner showed up, and you could see how rudimentary this one was. And you could see all of a sudden, I went backwards. There we go. You could see there was a problem here in the right frontal lobe. And I chose all these images specifically to show you kind of a similar thing. But here's a problem in the right frontal lobe, and you can see that, and then you can make a plan and say, all right, well, it's in the right frontal lobe. Let's go there. And then our CAT scanners got better. And you can see this is a new one here, where you can actually have really good granularity. You can see the difference between gray matter and white matter. You can see a problem here in the right frontal lobe. You can see the CSF spaces a little bit, and a big problem here in the frontal lobe. And again, these are x-rays. And then MRI showed up, and MRI is a whole different sophisticated system using hydrogen atoms and magnets and sound and echoes. But now the granularity gets even more. These black lines are vessels. So you can actually see the blood vessels in the brain around your mass. And based on the imaging features on different sequences of MRI, this is a T2 versus a T1, or versus a flare, sorry. You start to get an idea of how to predict what it is you're dealing with. And so just the advances in imaging alone have made us much, much better at diagnosing people, at understanding problems, understanding where problems are. And then we can do surgery better and safer. And that leads to the next thing, which is navigation. And so now you can take that image and you plug it into what's like a GPS for the brain, where you can actually, with millimeter accuracy, target where you need to go. And the way this works is it's on the left here, but you get a scan. And then in the operating room, we rigidly immobilize the patient. We usually put their head, these are pins holding the patient's head like a vice grip. And then you see this little magic wand here, and this stationary wand here. We map points relative to this stationary point, and then we map them relative to the MRI. And it allows you to basically register the picture in a three-dimensional volume on the patient's head. And then you can do things like create complex 3D images or representations of this, and start to map out things like where the tumor is, as well as your approach. You start to get a really good sense of, all right, well, I want to come this way or that way. And so this is ubiquitous now in neurosurgery. Every place pretty much has this. It's been around for a number of years now, but it's a game changer, because no more exploratory craniotomy, take half the head off and go look for a problem. Now, in fact, I can do a surgery through a 7 or 5 millimeter burr hole if it's a stereotactic needle biopsy, right? With millimeter accuracy. It's pretty impressive. And then we said, all right, well, we need more understanding, because the brain is not just, a bowl of mush. It's pretty important. We talked about this last time with the connectomics. So here's that image again of the tractography going through the brain. These are white matter tracts, okay, around the pathology. And here's our functional MRI showing the areas of the brain that light up when they're doing certain tasks. And we're able to now map these as well in our registration and our navigation system, so we can avoid these areas as we're doing them. And then I talked to you guys about this, which is kind of the next iterative step in this, where, well, okay, so we know that the white matter tracts are there, and we know that there's functional areas, but what network do they belong to, and how are they talking to each other? And so we can take that now and put that in our navigation system. So, the most amazing thing about technology is it's it's upgradable and immediately shareable, right? It's vast. Everyone can partake in the same kind of thing, and then you can constantly upgrade it, and it's layered and it's dynamic. And so you can keep adding more information on top of these things, and it doesn't overload the system or processing times and things. And that's kind of going to be a little bit of a theme of kind of what we're talking about today. Fluorescence guidance is a big and major changer for glioblastoma surgery. We talked about this, I think, in my last talk a little bit also. This is a molecule that the patient drinks a couple of hours before surgery. And in the setting of high-grade gliomas, certain meningiomas, and certain metastatic tumors, for whatever reason, the molecule is a precursor to something called the heme biosynthesis pathway. It gets metabolized into something called protoporphyrin 9, which it turns out is very fluorescent. If you shine blue light on it, it fluoresces this bright red back. And so it is very specific to pathologic tissue. Everything takes it up. A lot of things will transform it into protoporphyrin 9, but most tissues will transport it out or wash it out except for tumor tissue. And so you get this really brilliant red pinkish color glowing in the dark, which allows us to discriminate between tumor tissue and brain tissue, which is really important because in the past, and you can see in the picture, it's not always easy to tell what's pathologic and what's not. And like we said previously, we know that we got to get as much of this out as possible in order to really affect a meaningful change in that person's outcome. And we know that this has improved the volume of resection. We know that this has improved how long people live without the tumor coming back. That's PFS, or progression-free survival. We know that it increases how long people live overall. That's overall survival, or OS. Positive predictive value, negative predictive value. This is extremely high positive predictive value, meaning that if something is pink or red, it is tumor with a very high degree of certainty. If it's not, it doesn't necessarily mean that it's not. And that's a negative predictive value. And that's okay, because we also have our navigation to help us out. There's some of these other things we're going to talk about. What's interesting about 5-ALA, though, is that it extends beyond the contrast enhancing. So it's actually better than an MRI because it shows you where tumor is beyond where the enhancement is, and it's in real time. Whereas the problem with navigation is once I open the skull, the brain moves, right? You drain some fluid, it shrinks, the air gets in, it moves. Your navigation system is now off a little bit. And if you're trying to get every single last cell out and you're basing it on a preoperative picture, high likelihood you can be wrong. And so this fluorescence allows you to make real-time adjustments, which is super important. The limitations to this, it's a little expensive. It's not everywhere. And there's some evidence that it can create some light sensitivity for patients if they see too much sunlight afterwards. I've never seen it happen, so I don't really fully believe it. We get into our actual intraoperative things. What can we do to make things better? And I know you guys spoke to Dr. Silverstein yesterday. The idea here is, and we talked about this the other day also, which is safe maximal resection. If this is your tumor, this green ball here on the left side of your screen, we want to get that out without interfering with these purple tracks, right? Because then you're going to cause dysfunction, neurologic dysfunction. There are different ways to do this. We can take out only some of the tumor, which is what you're seeing here. We can take out the purple track, which is not good and cause an injury. Or what we want to do is leave a rind of tissue like this along the important areas, but we want to really minimize that. And so we developed these abilities to, or the ability to do what's called subcortical stimulation. So we can monitor you through a probe that we put underneath under the brain tissue. We can do cortical or subcortical. And we pass an electrical current through the motor strip, through the cortical spinal tract, and we measure the outcomes distally in the limbs. And it turns out if we electrify our instrument, we can actually, we can kind of downgrade the amplitude or the voltage, whatever we're getting to, and understand how we get closer and closer and closer. And it's shockingly about a milliamp per millimeter, which is great. So we can basically start at 20 and say we're 2 centimeters away. And when we get down to 5, we can say we're 5 millimeters away. And then we can actually slow down or stop. And generally, I use 5 as my threshold. We have developed things like awake mapping. And then we didn't develop this. This has been around for a long time. But for eloquent things that are more complex than what we can measure just with simple electricity, we need to wake patients up. Here's an image of someone playing guitar while they operate in his motor strip. Just someone talking to you. This is pretty standard. The drapes are over the face. We have maybe a microphone here, or the neuropsychologist is sitting here giving a test while the patient is awake. And that test involves a lot of different things like naming or sentence completion or pictures, picture identification. And here's what it looks like in the operating room. We see this area that is presumed to be tumor, and we map the really important functional areas behind the tumor, and then we stay out of them when we do the actual tumor resection. And it's not just on the cortical surface we have to worry about. Remember, the white matter tracts are underneath. And so we have to be able to map and monitor all these things. So we use something called an augmented stimulator, which is a bipolar stimulator under when we're in the subcortical zones, and we stimulate the white matter tracts so that we know where we're going also. I love awake surgery. It's young women are the best at it to undergo it. Young men tend to complain a lot. We can talk about that maybe in the Women in Neurosurgery lecture later. But in general, it's a really rewarding technique because people help you do their surgery, and I find it's really incredible to watch the strength some people have to be able to go through this. I'm not sure I'd be able to do it so easy. It's a good question to ask yourself. So I told you about this. This is our subcortical mapping. So yeah, you can use a monopolar probe, but what we and what Justin Silverstein and myself decided was let's electrify our instruments. So we insulated our suction that we use on a daily basis, and we put that in the brain, and we're able to identify areas of response so that we know we're getting close. And we especially did this, excuse me guys, I'm sleepy today, in the left lateral frontal lobe for asleep motor speech mapping. So language, when you get into things like the posterior temporal lobe, where it's really integration, it's understanding context of words and syntax and then producing meaningful speech, that's really complicated. But the production of speech is a motor issue. It's coordination. You have to get your air, your vocal cords, your mouth, your lips, your tongue to form certain words. But that's still just a motor response. And so we can monitor that. And we've published a pretty large series looking at this. It's inconsistent. It's difficult to interpret always, but it's good. And we're still doing active work on it. This is a really cool technology. Came out of Michigan originally. A guy named Dan Oranger, who's now at NYU, where he's able to use something called stimulated Raman histology to visualize tumor tissue. So what we typically do is we take a piece of tissue and we send it up to our pathologist, who freezes it, and then they slice it, and then they look at it under a microscope. And it takes about 20 minutes or 30 minutes. And then they come back to us and they say, well, it looks like it's a glioma, or it looks like it's a metastatic carcinoma, or it's non-diagnostic. Can you send me some more? What stimulated Raman histology does is it's basically spectroscopy. It looks at the tissue and then uses a machine learning algorithm to generate this image that looks like a frozen section. So it's a virtual frozen section. It does it without destroying the tissue. Oops. And it's able to do it in about 2 minutes in the operating room. So instead of this 30 minutes waiting for a call to tell you didn't get the tissue, you got to go back, you get an answer in about 2 minutes. On top of that, what's even more interesting is those machine learning algorithms have been taught, and they're, at least in neurologic disease, able to identify the tumor tissue accurately like 95% of the time, which is equivalent essentially to a radiologist or to a pathologist who's been trained in this. And so, this has not expanded too far out of really New York City. I'm not sure there's that many places using it. We used it a little bit and then we sent it back. We're trying to get it back again. But it's a real game changer, especially out in the community when you need an accurate diagnosis. And because it's spectroscopy, there's a chance it can identify things that take sometimes longer for pathology to identify. Things like co-deletions of certain chromosomes or mutations that are important for prognostication. So there's a lot of potential here, a lot of research going on with it. I think it's a pretty unique technology. And the goal here is to do something like this, right? We take a large tumor and we're able to use all these things together. It's not one thing's better than the other thing. It's using all this tech to really get a big total resection of something like this, and safely. Now, Dr. Benchlum, did he talk neuroplastics yet? I think he usually gives his talk.
Yes, he did.
Yeah. So sonolucent implants is something that, it's funny how the word technology can be used. It's a technological advance. It's plastic. It's a plastic dish. But what's amazing is how you use it. So it's sterilized, it's prefabricated, it can be molded directly to you, 3D printed, and it replaces a portion of the bone. And it allows sound to go through. And so our ultrasounds, if they've gotten better, can now pass through this. And what can we do with ultrasound? So with ultrasound, we can potentially look at the brain through one of these implants, and we don't need to get a CAT scan or an MRI necessarily, especially for pathology. But can we do other things? So right now, I have a clinical trial where I implant a piece of bone with an ultrasound in it. It's an artificial bone with an ultrasound probe in it, and it sonicates the brain at a certain frequency, and micro bubbles open the blood-brain barrier to deliver chemotherapy. Well, if we have a plastic plate on the side of your head that can allow sound through, why do we need to put the implant in? We can just put this one in at the time of your surgery, and at your recurrent surgery, we can sonicate through that. I'm hoping that this opens a lot of avenues towards improving treatment. We'll be launching that clinical trial soon as well. And the other thing is looking at things like treatment effect. So one thing we don't talk about a lot in BRAINterns because it's an introduction is interpreting after treatment MRIs is not always easy. Sometimes it looks like the tumor is progressing, but it's just the tumor responding to the treatment. You don't want to operate on something that's working. So figuring out the difference between what we call treatment effect versus tumor progression is really important to the patient, because if the treatment's failing, they need surgery, or they need more treatment or different treatment. If the treatment's working, they don't need surgery. So how do you know that? It turns out that, with enough ultrasound images, we may be able to tell that through these implants also. So something that, again, is actively, going to transform things. And even though it doesn't feel like technology, like, oh, there's a robot doing my surgery for me, but still really, really important. Post-operative treatments like clinical trials. And again, you're going to hear from Tamika and Co about this. This is the way that treatment advances in our country and the world. Really, we have to be able to do clinical trials. We have to be able to participate in some sort of experiments for the problems, and basically it's just like anything else: identify a problem and then figure out how to solve it. We run a ton of clinical trials here. This is one of our intra-arterial trials where we deliver chemotherapy through the artery into the brain, and we open the blood-brain barrier, and the chemo gets to go right in, rather than passing through your veins, through your heart, through your liver, where most of it's processed before it even gets to the pathology. So it's that's one of our trials. We have a bunch like this. Like I said, I have one where we do ultrasound to open the blood-brain barrier. We've got a new leptomeningeal disease trial, which is for patients whose cancer goes to the lining of the brain, which is usually a really, really, really tough problem. But we're working on that. GammaTile is super cute. This is, we give, for many types of cancer, we have to treat with chemotherapy and radiation of some sort. Radiation typically comes out of an emitter outside of the head and passes through you and radiates the field. What GammaTile does is it takes radiation seeds, these little, you can see the little black threads there. These are cesium-131 seeds. And we line the cavity of your tumor so that the radiation treatment starts day one, not the classic 3 to 4 weeks later, which we have to do to allow your wound to heal. And so this is a really valuable situation, especially in people who have had radiation before, because this allows you to deliver a very local dose without affecting the skin or the surrounding areas. We started using this a lot. It's called brachytherapy. The collagen just dissolves. The cesium-131 breaks down radioactively very, very quickly, so your family's not at really any significant risk. And most importantly is you start the treatment immediately. You don't have to come back 5 days, 10 days, 30 days in a row like you do with some of the external beams. Dose intense treatment we talked about. This is more GammaTile. You can see there's a smooth and a rough surface. We just lay these tiles around the resection cavity again. Recovery, we're super interested in this. And I talked about this during Connectomics also. How can we make the brain better after a surgery? So transcranial magnetic stimulation is one of these options where we're able to use magnetic waves to turn on and off areas of the brain. We can increase function or turn it down based on how we target the magnetic waves using navigation. And so again, I think I mentioned this, we're still looking at this. There's a lot of interest in it. Jury's out on the efficacy, but it's coming down the pike. Augmented reality. This is something near and dear to my heart. I don't, and we just published an editorial about how I find it very difficult to study, but I think it's super important. So what have the studies shown? The studies have shown that for training purposes and education, this is the way to go. It's 3D high fidelity, and I go back to that word layered imaging that you have preoperatively. You can take the patient's own MRI and map out their pathology and then start to layer on some of these important things like the tractography, the connectomics. You can register this in the operating room. So you have a 3D representation. That's what you're seeing here on the bottom. That allows you to really see the anatomy where it actually is. And so super important. And then I think that component of it being layered is really important. So you can put more and more information. What we just started doing with this now is actually thinking about it more like the Apple Vision Pro, an option for spatial computing. And so the registration is amazing. The imaging is amazing. We get that. But how do we use that, right? How do we study that? How do we measure the effects of that? It's really difficult. But spatial computing is really cool. And if I can use a computer attached to my eyes while I'm sterile in an operating room, and I can turn off and on the connectomics, or I can bring up the patient's history, or I can, conference in with Dave Langer because I needed a little help with something like that. All of a sudden this becomes really valuable and visible to everyone kind of as we do it. And so I think that's kind of where the future of this stuff is going to go. But it's extremely exciting to have, and I think it's very, 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 very valuable and underappreciated right now. What about also post-operatively things like playback health, which I'm not sure Dave has talked to you about. We have communication is key, and we are the age of social media. And so we use this service, which allows us to record our conversations with patients, because it turns out they forget the majority of what we say. And we can show the imaging and talk over it. And then it automatically goes to them and their loved ones, or maybe their doctors, in which case all of a sudden everyone has a summary of what happened. This incorporates large language models now that summarize the conversation. And so my charting now is easier because playback records what I says and delivers it to me in a format that I can use to chart. The most important part, though, aside from my life being easier, is making sure the patients understand what's going on with them, which this allows us to do. It allows us to ensure quality is going to be okay. And that's kind of the end of that talk. Let me see if I can stop sharing for a minute. A little bit short today. I wanted to see if I had some videos of the 5-ALA working.
Yeah, while you do that, BRAINterns, if you want to go ahead and ask questions in the
Yeah,
Q&A.
now's the time. Here, I'm going to share. Is that, let me share again real quick. Can you see that?
Yes.
So this is what 5-ALA looks like. This is using loops, which are just like the eyepiece with a light attached to the top of my headset. And you can see how it glows the tumor really red, and we can see the difference between the purple tissue on the outside. What's really nice about the loops is it's bright enough that you can actually do the operation. What sucks for you guys is I'm shaking my head and talking the whole time, so it looks like we're having an earthquake. You'll see on the next one, it's going to be different. But you can see how bright and different the tumor is from the regular tissue, right? Like that really, really interesting bright pink phenomenon. And so that's that one. And then when we use the exoscope with it, this is now exoscopic. And this image actually is first. You can see the image is much more stable. You still get the idea that it's bright pink and white. You can see we're using our subcortical stimulation device. And this is what it looks like when we get to the margins. It turns less red and it goes more to this kind of light pink. And that's how you know you're kind of at the end of where you need to be. And so each one of these has a nuance to what the imaging looks like or what the tissue itself looks like. But you get used to it with experience and trial and error. Sorry, my nurse is texting me. All right. What else? Let me stop. That stopped sharing now, right? I'm back. Let me see if there was anything else I wanted to mention to you guys. The only other thing I think is, again, a conversation just on, that's kind of it for now, on tech being, immediately shareable and upgradable. I think that it's a really important thing. I mean, obviously some of the stuff we're using is really expensive neurosurgical specific stuff, but I think, the real trick to how things are going to get better in the future is understanding that we're in the midst of a real significant technological revolution, especially with the kind of the insurgency of AI. And I really wouldn't be afraid of it. I wouldn't be scared of it. I would use it. I wouldn't cheat with it, right? I wouldn't use AI to write my papers and say like, I'm going to get great grades now. But I would use it to make me better, because it's only going to do what you want it to do, right? And so, use it in a way that makes you smarter or better. Take its suggestions and then add it back in your own. Make sure it's actually saying what you want it to say. Be in control of what it does and use it to your ability. I write papers with it now where I don't have it generate the paper. What I do is I write my ideas, and they come out sounding like me talking, like a non-eloquent heathen, like a brute. And then I ask it for its ideas on the same thing. And then we put it together, and we find the best way to say things, and it makes it more efficient. And sometimes it's really, really helpful. And I'm really excited to have it as part of what I'm able to do. It doesn't change that it's, our ideas coming forth, or telling it to do that. So yeah, I mean, I don't know if the questions are open. The chat's pretty quiet right now. I really appreciate you guys' time, but
Yeah, they're coming through the Q&A
oh,
section,
cool.
but I think Samantha will ask you them as they come in.
Yeah,
Yeah.
we're kind of keeping track of them. So if you want, I can just throw them at you.
Yeah, go for it.
So going off of AI, we have a few questions about it. Beyond summarizing information, what are some emerging ways that generative AI is being used in neurosurgery?
So right now, and we've published a few papers on this, it's I think the ambient listening component is really important. When I talk to a patient, I hit record on an ambient listening playback, in my on my phone, and it records the whole thing. And they get the audio version, and I get a summary version, so that I make sure that we've talked about everything. It helps with our documentation and everything like that. Then on top of that, we've published a few papers now on how to use it for things like triage. So it can triage just as good as junior and senior residents, which is pretty amazing, especially GPT-4. And now we've started to look at how to make our own GPT. So I don't know if you guys know this, but you can personalize GPTs in a way. You can kind of hyper train them on certain information. And so we just published a paper looking at Chiari malformations and the ability of the GPT to stick to consensus recommendations, and it's very effective. And so I think rather than asking me what to do with it, because I'm old, it's challenge yourself to figure out what you can do with it, right? How can it make the future better? Then dive on it. This is like open access stuff. You can kind of do whatever you want with it. It's pretty incredible. I told you I'm using it to help write papers. I use it to help organize papers. I use it to help teach students how to write papers. I think I learn a lot from how it phrases things. What you want to be careful about is making sure that it's not, doing the job for you. You really do still want to you want to guide it. And that's why I think the best thing I've ever, heard about it is it's a collaboration. All right. It's not thinking on its own yet. I'm waiting for the day where my phone texts me and says, "Hey, I thought of the cure of cancer," but it's not there yet, right? So I think the other really powerful component of it is it's the ability of not just generative, not just GPT tech and large language models, but machine learning, algorithms in general to just digest large quantities of data. We're able to do so much more than we can do independently, and so much faster.
Awesome, thank you. Another question that we have about AI, hold on, let me find it on our list. I totally just lost it. Okay, never mind. scrap that. Someone asked, how do you come up with different clinical trial ideas?
That's a great question. I think it's important for Tamika's group too. I would ask the same question later on today. What happens with a clinical trial is you have an idea that you're reading the literature, you're reading the scientific data that's out there. You've seen a few things in your own practice, a few associations, and then you say, well, maybe there's something there. Let's study it. And then you go back and you see how many of the people that you've ever encountered with this had this. And maybe you say, well, there's a trend. Or, I think there's a lot of evidence that says that targeting this protein is going to help people, right? And so you have to start in kind of the preclinical world or the observance world. And then you say, well, I now firmly believe that this is going to work, or I think this has a really good rationale behind it that it's going to work. So I want to study it in a systematic way. And then you have to write a trial, and that trial needs to be written in a way that excludes as much bias as possible and produces enough data that you can make statistical judgments of the efficacy of what you're studying, right? And so, I once went to my boss a while ago for advice, and I was having trouble. It was when I first started in research, and I was having trouble. I wanted to write a paper on some preclinical studies I was doing, given mice chemotherapy and radiation. And I wanted advice, and I sat down and I was like, well, what do you think? What do you think I should do? And he said, well, what you need is reproducible evidence of statistical significance. That's not advice. That's the definition of science and research. It was the worst advice I'd ever heard. But at the same time, it was like poetry, because it's exactly what you're looking for. And so to design a clinical trial, you want to get to reproducible evidence of statistical significance, because that means that what you've done works. So again, you start in that preclinical world, you start in the rationale behind something, you start in observances, and you carry it forward in this stepwise approach until you can design a trial that allows you to get that reproducible evidence of statistical significance, because that means that what you've done worked. As long as all the other criteria are met. So that's kind of how we do it.
Absolutely. Thank you. Someone asked what advancements in neurosurgery you hope to see in the next few years.
In neurosurgery, I think that, a sleep speech mapping is the dream. I think, for me, I've said this before, I don't think surgery is the answer for a lot of what I deal with. I think it's necessary, but I think that neuro-oncology is a medical disease. We need to figure out how to treat glioblastoma and gliosarcoma and chordomas and all these, and grade 3 meningiomas, all these malignancies that devastate people. And so those advances are going to be made in molecular biology and targeted therapies, which means that, machine learning AI is going to help with all that, large data quantification and evaluation and understanding. Just physically speaking, I think, I want the Apple Vision Pro to be my new set of loops and my augmented reality and my, and understand what's happening in front of me and talk to me while I'm operating. I think that, operating like that with a comprehensive, dynamic, layered, AI assistant is going to be the greatest thing, for you. And if you want to add some robotic components too. But I don't really see, whether it's AVP or whether it's, the HoloLens, whatever company does it, that's kind of the goal for that. Otherwise, I think the advances are going to be made in the molecular biology world. That's what I think really helps. And then obviously, neurorehabilitation. So, all these people who have been afflicted by a neurologic disease or disorder or damage, an ability to make them better. That's kind of the goal in the future.
Thank you. Kind of going off of that, someone asked if you think it'll be possible to reach a point in technology where you could remove a tumor entirely rather than leaving a rind behind.
Yeah, why not? Or just treat it medically, not necessarily surgically, right? I've said this before in different iterations of BRAINterns, but surgery is archaic. I love doing brain surgery, but it's insane, right? It's like warfare. Like we use a knife and some string, and we're like, we're going to make you better. You're like a complex organism with, you know, millions of genes or whatever, thousands of genes and proteins in your body, and I'm going to come at you with a piece of steel and a string, and I'm going to say I'm going to make you better. That's insane. No, we need to be smarter than that, and we need to make it better in a different way. And so that's where, again, I maintain that this is, you know, a lot of this stuff is medical disease. It's genetics. It's understanding how to change that or augment that or fix that.
Absolutely, thank you. We have a question asking if you've ever used augmented reality while doing a brain surgery.
Yeah, absolutely. Let me see. I don't think I have the video on here, do I? Hold up. Let me show you what it looks like. And this is still kind of new. We're still working on it. There are always issues with a little bit of latency issues with the image processing and a little bit of lag. And so it's hard sometimes to actually do. Sorry, I'm searching for something. The surgery right now. Let's see. I've got a few different pictures. Which is a good one. Sorry, I'm looking for. All right, this one's pretty good. It's a little jumpy, but it's pretty good. Let me share. Can you see the video screen there?
Yeah, we can.
So this is intraoperatively. And what you're looking at is this screen doesn't exist. This is a virtual monitor. Basically, the microscope or the exoscope output is virtually held in space, like you're watching a movie in space. And it's a little jumpy, like I said, but there's the 3D volume that you can manipulate while you operate. It smooths out there a little bit, and there's the face and everything. And then this is the actual operative screen, which you can move around wherever you want it. And so, like I said, again, you know, you have the ability to layer information here. Now, this one doesn't do it because it's just, you know, the first example I could find. But you could put the connectomics on here. You can put the tractography. You can't really overlay it on your operative output monitor. Let me find a better image because this is giving me schizophrenia. Hold on. Let me see if this one's better. Nope, that one's not better. That one's not better. How about this one? All right, I think this one's a little bit better. So here's another version of this. So again, this is the tumor volume. This is operative image that's just kind of floating in space. You can see the students walking around. That student's not appropriately covered on her nose. But kind of insane, right? And it's high resolution 3D imaging. The 3D is not as good as what you get with the exoscope screen. That's another thing where I think you know, certain components are going to make this better. But it's the same thing you're seeing on the big screen. You can mobilize, you can put it wherever you want. You can get access to the volume. This can be registered to the patient, so you can actually register where you are in actual space on this. And you can see that really important blood vessel over the top of this. So you know you're getting close to that because you're coming in here and if it's registered. So overall, just I think a really promising way to do this. I think it is going to change, you know, things moving forward. I think it'll be more ubiquitous, more user-friendly once we really figure it out. I'm like the only person in the world doing this. So this is like extremely, this is a real insider view right now, guys.
That's so cool. Thanks for sharing that.
Yeah.
We have a question asking what the fluorescent molecule for guiding surgery is made of and how long it stays in the patient's body, and also if it just gets absorbed.
Yeah, fully absorbed. It's called 5-aminolevulinic acid. The commercial name is Gleolan. it gets metabolized. So it doesn't, it gets metabolized into protoporphyrin 9, which is a normal byproduct of one of our pathways, the heme biosynthesis pathway, and you just absorb it. Or you take out the tumor and you take out all the pink stuff. So it goes away in about 48 hours, probably.
So cool. Someone asked if there is or if there are any advancements in technology that are being used specifically for time-sensitive operations.
Meaning, I'm not really sure,
More in
what
emergency room neurosurgery.
everything I've told you can be used really, really quickly. Any CAT scan that has 1 mm cuts can be automatically navigated. That's what we use it for. Once you have a navigated scan, everything else is based really on the navigation. And so, I think that kind of stuff is very, very quick. 5-ALA, you need 4 to 6 hours, but there's almost never an emergency gliomat operation. Steroids will usually temporize it until that works. And so, yeah, no, I don't have there's not really anything that's really, really new in the acute setting like that. We have different drains. Some of our EVDs are used when someone has something called hydrocephalus, typically due to a brain bleed. Some of them now have pumps where they can pump irrigation through them, which can allow, resolution of the blood clot a little bit faster potentially. But in general, everything that I've talked to you about can be used very, very quickly.
Awesome. Thank you. Someone asked, just out of curiosity, sorry, I can't speak this morning, if you've ever encountered any interesting cases like a modern day Phineas Gage.
Every case is interesting. The brain is wild. And when you see the kind of deficits that people develop or encounter, it's so variable and so interesting. So every single one. I've got a guy, right now who, he has a lot of difficulty speaking, but he understands everything that's going on. And the way the brain makes connections of words, what he says instead of what he wants to say, is just so interesting. It's hard for me to describe it, but no, it's absolutely incredible. Every case is Cage.
Someone asked if you use connectomics and tractography in all tumor surgeries.
I will use connectomics in every intraaxial tumor. I will no longer do it the old way. And it's not that I necessarily think every case is dangerous. It's that I want to know what I've done and I want to understand how they've changed, if they've changed. So every single case.
Absolutely. Someone asked how developing countries are or could be profiting from these new technologies.
Yeah, this is tough. The internet democratizes technology to a degree. Things like AR can really, really benefit developing countries, because you're able to have someone, again, it gets back to that component about technology, that it's immediately upgradable and shareable. Everyone, can be upgraded to the same level globally, and everyone can share things globally. And so you have a way to level the playing field a little bit. Look at this right now, right? How many people are listening? 95 people, 94 people from a variety of different countries getting the same kind of educational components. And so I think the goal there is democratizing education and so forth, and then therefore outcomes. The difficulty is not everyone can afford a $250,000 Raman spectroscopy machine, right? And that's the rub, but the education, the knowledge part is free. It's out there. And that's what we're trying to do, right? By showing people what exists and what can be done.
Absolutely. Thank you. Someone asked if the effectiveness of gamma tile has been tested.
Yeah, the efficacy is the same. It gets you about 60 gray at 5 mm, which is a really high dose of radiation. And so far, the studies have been equivalent to repeat radiosurgery with less actually radiation necrosis risk, which is interesting.
We have a question asking how you decide what modalities of imaging and investigation to use.
So it's based on where things are, and what you think is going on. So that's why you guys are all going to go to neurosurgery residency, and you're going to learn. Guys, I know it's 10 minutes early and the next one is until 10:30, but today is my clinic day. That's why I've dressed for the job I want. and I have to go see patients, and my nurse is texting me that I have to do that. So I love spending time with you all. I've had a wonderful morning, but I'm gonna go see people, try to fix people. So stick around. I think the next one is at 10:30. I'm not sure if you guys are gonna just linger or turn it off for a little bit, but it's always a pleasure, and I can't wait to see the other 2 lectures today. So
Thank you so much, Dr. D'Amico.
all right, guys, take care.
Thank you.
Hey, Hannah.
Hey, all
She's-
right. So we have, I've been here the whole time, I promise. So like Dr. D'Amico said, our next speaker will be at 10:30. Thinking we can just keep the session open, but instead of like ending and then restarting, so people don't have to rejoin. So we will be back. Do you guys want to hop back on like at like 10:20, 10:25?
You can do that.
Perfect. All right. So BRAINterns, you get a coffee break. If it's the afternoon, you get a snack break. And we'll see you at 10:20, 10:25 EST.
Yes.
Absolutely.